Okay. So thank you everyone for being here. I'm going to do a quick introduction and say I'm Dr. Yeraz Markarian and Director of Psychology and a licensed clinical psychologist at Hackensack University Medical Center in New Jersey. We've been, as part of Armenian Mental Health Initiative, Dr. Ogarian and myself have been leading these psychological first aid trainings, among other trainings, grief and loss trainings, acute stress disorder trainings, as well as traumatic brain injury trainings, among others. So whatever the need is in Armenia, we're responding to it with many different contacts there on the ground. The Armenian Mental Health Initiative is 150 strong at this point, with volunteers, all mental health professionals, and we look forward to collaborating with you all and being here to support you in any way that you need. I'm going to ask everyone to mute, and then Dr. Ogarian, please take it away, introduce yourself, and then let's go.
Oh, sure. Hi, everyone. My name is Valentina Ogarian. I'm a licensed clinical psychologist at UCLA. I specialize in oncology. I think Yeraz did a pretty comprehensive effort in summarizing sort of the initiatives that we've been working on. And, we wish you the best when you guys depart, and we are continuously here for any way we can be helpful. One quick note, just so you guys are aware, and you probably are, but this psychological first aid training, we have already facilitated as a training to a pretty large group of mental health providers in Armenia, as well as family physicians.
Okay.
So really, I think here I don't know everybody's, of course, level of expertise or familiarity with facilitating PFA or receiving PFA, but the goal is to think about, do all survivors actually develop severe mental health problems or needs? Is there really a clear-cut typical emotional response to crisis? And are emotional responses considered healthy after crises? And these are sort of thinking points for us to consider while we go through the training. So here are some basic goals of PFA. One of the things, I won't go through each one of them, but very quickly, it's really about increasing safety and reducing uncertainty, right? The literature would point us in this direction, that someone who's come out of a crisis needs that level of stabilization of safety. One thing that I think is really important as a takeaway is to establish a human connection. So that's primary, and to also maintain some level of expectation or consistency with the person that you're meeting, as in who are they meeting with next and what's about to happen next after your encounter has ended. What is PFA? It's first-line psychosocial support. It's evidence-informed, so there has been significant research to show the effectiveness of PFA as an approach. It really fosters functioning and coping for the individual that's been impacted by that level of crisis. And one of the, I think, most important takeaways is that it helps to reduce the risk of developing PTSD in the future. Right. It's not counseling and it's not debriefing. This is something I think important to note, and something that we've highlighted with our colleagues in Armenia, that we're not doing psychological counseling or therapy. We're really just focusing on stabilization, safety, and connection and assistance to practical needs.
And if I can just interject, I think for mental health care providers, it can sometimes be challenging because our go-to is counseling. But we know from the literature that doing therapy counseling, and counseling in the sense of trauma debriefing, can actually do more harm than good while a crisis is ongoing. And for many right now, it still is ongoing. So we're not doing, tell me about the trauma, tell me what you saw. That's really not the goal here. We'll get more into that in a few.
Mm-hmm. And right, we are still in a pretty acute state, and we're going to be in an acute state as long as the war continues being active. PFA, who, when, and where. So any individual across the lifespan can benefit from PFA during a crisis, which many people are in currently. When it should happen immediately after the distress or the crisis event has taken place, and where, I mean, ultimately, ideally, the goal is to maintain some level of privacy that is appropriate to the situation to be able to facilitate this type of an approach. We also recognize that that's not always possible. So again, as I said, I think ideally the goal is as much privacy as possible. Okay. Before entering the setting, you really want to know the lay of the land, and I think this will be particularly applicable to all of you, as you know, depending on where you guys will each be. But you want to identify the roles and the rules of the setting that you're in and the context that you're in. So understand, you know, how does this hospital operate? How does the center operate? Who's essentially the person who's a liaison or helps with triaging? We want to learn basic policies, procedures, security, and what are available resources. So we really want to be mindful to not say, oh, we'll refer you to the next kind of medical team member, but then in fact find out that there is no medical team member available at that setting. And we want to find a designated area for PFA. That's not always possible, absolutely. But you know, even if it's in a hallway, if there's any sort of remote privacy, we encourage that. So, who is a priority patient for PFA? This might feel very inherent to all of you if you are a mental health provider, but we really want to scan the room and focus on the individuals who are either exhibiting or behaving in the following ways. So, incredibly disoriented, confused, frantic, agitated. You know, they're demonstrating sort of panic. And then when there's a specification here, I think it's normal for there to be a sense of feeling withdrawn or irritable, but this is sort of more of the extreme withdrawn, apathetic, extreme agitation, extreme irritability, and feeling exceedingly worried.
Thanks. So the fundamental principle of PFA is that we assume each encounter is all encompassing. So we don't assume that we're doing 3 sessions or 8 sessions or 20 sessions or 500 sessions. We assume that we're meeting them once and that all of the things we're about to go over would ideally occur in that one single encounter. The main focus is that each encounter provides affirmation, kind of an authentic affirmation of their value, their service, their dedication if we're dealing with soldiers, as having learned a sense of something of value about themselves through this crisis, and also how they can actively find meaning or achieve some kind of goal in the face of the current crisis. These are the 8 main points of PFA. We want to encourage you to do all 8 of these in each encounter. It sounds like a tall task, but I think once we get into it, you'll see that it might not be. So initially, and remember that PFA is for not just mental health care providers. Anybody on earth can learn PFA. So there are some things that are going to seem very basic to you guys, but it's important for the purposes of the training that we're all being consistent. For contact and engagement, we want to make sure all of this is also done to reduce the anxiety and to reduce the uncertainty of the soldier or the patient that you're encountering. We want to make sure we identify ourselves. I'm a psychologist. This is my role here. I'm going to talk to you for a little bit if that's okay with you. We want to make sure we ask permission. So much has been taken out of their hands and so much uncertainty, so little that they have control over. We want to ask them permission even to talk to them, of course, beyond in just regular informed consent. We want to ask them what name they would prefer. Typically, we refer to them by their last name as a sign of respect, and that's sort of a military-esque thing, if you're dealing with the soldiers directly. Of course, I think for most of you, this is going to come naturally to speak softly and calmly. We want to remember that no matter how stressed we are, we want our emotions to lead the way. We want to model, behaviorally speaking, the interaction. So if you have faced a few patients right beforehand and you're about to walk in, take a mindful moment, breathe before you walk in, and remember that each interaction is being modeled for the patient as well. And we can be that oasis for them. Again, with privacy, we bring this up because we're not in our private practice and comfy offices. We're bringing this up because, as you well know, these are hospitals. Sometimes you're going to see a patient in a corridor. Sometimes you're going to see a patient right next to another patient who's agitated. So if there is a way to set up some semblance of privacy to the point that it's realistic, we want to do that. And we want to make sure that no matter what's going on in the room, we don't get distracted, that we have laser focus so that they really feel like all of our attention is on them. And we want to assess exactly what they need, what their pressing problems are, not what we think is necessary for them in this moment. So, of course, I'm here to listen to you, provide support in any way that you feel help. How can I help? What is it that you need right now? Is there anything I can help you with? They may need you to do something physical, like give them a pillow and make them feel more comfortable. Okay, then that's what we do. They may say they're hungry. Okay, then that's what we do. Basic needs, Maslow, right? Whatever it takes. And we also do want to indicate that, that there is this aspect of confidentiality, that everything stays between us unless you indicate to harm yourself or others, right? You guys know this as clinicians, but we also want to emphasize, and if that's the case, we'll work together to find you or the other person, who might be at risk, all the help that you need. I'm here no matter what. Creating that connection, the genuine connection, is really key. So we're going to refer to that a few times here, but of course, empathic listening to understand what they're really feeling and thinking. The second thing we want to do is, as Valentina mentioned earlier, is create a sense of safety and comfort. So the restoration of safety is one of the most important goals of PFA. As I mentioned, they've had so much uncertainty, so much of feeling out of their control. So that's going to come, vis-a-vis information. So I think you're going to not. I think maybe you'll get transported. I have found out you're going to get transported tomorrow. You're going to go to such and such hospital. You're going to meet, if you can find the name of the doctor there. This is who you're going to meet with there. Status updates, letting them know what's happening to reduce the uncertainty. This is going to inoculate them and prevent them from developing PTSD later. If you can help them contact a loved one, that's also going to be really key, if that's possible. Physical safety, attending to medication, increasing their comfort. Like I said, giving them food or providing them with a pillow. People are going to be running around, nurses, doctors, everyone's going to be busy. So you might need to be, housekeeping. And that's part and parcel of PFA as well. We call them environmental services in the hospital, but you know what I mean. And anything else in terms of daily living. They might need a shoe tied or, a button buttoned or whatever it may be. Make sure to keep a list of those survivors or those patients that you see who have special needs so that that list can be referred to the next on-call clinician and they can be checked on more frequently. And I think, obviously you guys know this, creating safety by listening attentively, non-judgmentally, no matter what they tell you, we're with them, right? Focusing on their core strengths and their core values. We want to make sure not to offer generic reassurance and generic coping. Well, you'll be fine. Your friend's in a better place. You're safe now. The war will be over soon, or any promises that you can't fulfill. This is actually deleterious for the soldier or for the patient. We can't do that because we can't promise any of that. We can't know we can't know what we're reassuring them about. So we really just want to stay consistent with facts. The stabilization piece, remaining calm ourselves and sort of inducing calm in them just by which is not really what I'm doing right now because I'm a little bit keyed up because it's late over here in New York. But right, we want to have a soft tone and speak slowly and gently and create that sense of calm with our effort and all of our energy. Giving them space, giving them the space to talk about what they need to talk about in that moment. We can use orientation and grounding tactics for those who are distressed or disoriented or overwhelmed or underwhelmed. Sometimes those who are not speaking respond really well to physical tactics of squeezing a ball or, playing cards, falpanal, whatever, right? So anything that we can do to get them physically moving and engaged in something is going to be helpful for them. Focusing on their manageable thoughts, their immediate priority. What is it that they're worried about? What is it that they need? And orienting them to safety. So, of course, we create calm by the reflection space, the self-awareness space, not a reactive space. We don't want to let them judge themselves either. I can't believe I'm feeling so sad. Of course, you're feeling sad. Your best friend just died, right? These things come naturally to us, but we want to remind ourselves to do these things with them. And creating a sense of efficacy. Self-efficacy is this idea that you're capable of accomplishing what you set your mind to. And it is so unbelievably healing. It underlies so many other constructs in psychology, including the development of resilience, which is going to inoculate them against PTSD as well. We want to genuinely validate what they're already doing and how to care for themselves and others. Information gathering, I'm not going to go through this too heavily because this is something you guys know so well. We're assessing risk for PTSD. So we have some standard questions here. Where were you during the disaster? Did you get hurt? Did anyone else get hurt? Were you scared? We want to keep a list of those who are at risk. We want to assess other factors that are risk factors for developing PTSD later, death of a loved one, worried about someone close to them, or if someone's missing, physical concerns, property loss or damage, and history of prior trauma. So again, keep a list of those who have those criterion A, or things that might contribute to, the criterion A of PTSD. You want to keep that handy. Practical assistance. So for practical assistance, discussion of immediate needs really needs to occur throughout psychological first aid at any point in time. We want to help them identify their needs, and as such, problem solving might be more difficult under conditions of stress and adversity. So teaching them how to set achievable goals may reverse feelings of failure and their inability to cope. So that's going to be really, really key. And what we create what we want to create through practical assistance is offering hope, enlightening, and creating that hope for them and empowerment so that they feel, again, that self-efficacious, precursor to the development of resiliency and to help restore their dignity in whatever way we need to. Focusing on one need at a time. And I think that's it, Val, for me. Right?
Thank you, Yadav. In terms of connection with social supports, I think, as we all know, it looks a little bit different in Armenia in terms of access to support, but we really want to help assess current social support and what their level of access is. We don't want to make assumptions that they have perfectly fantastic relationships with every single family member. We want to kind of identify who their gatekeepers are that would either help foster or limit that support. Why does it matter for there to be a sense of fostering social support? Because it helps increase the sense of feeling needed or valued by others. It feels like they can belong, there is a connection, and it helps build their confidence in their abilities. We want to take practical steps to help them connect to loved ones, including faith-based. I know that let's talk kind of factually in this moment. COVID-19 is a pretty significant concern at this time. So I know that hospital settings, as you guys all know, since you're going next week, are trying to take measures to limit sort of incoming visitors. But I think we want to be kind of mindful and thoughtful. What's a visitor that's necessary for fostering that social support, and how do we do that to maintain their safety with COVID? We don't want to, I mentioned this already, assume that their personal relationships are supportive and overlook possible areas of tension. We really don't want to provide simplistic reassurance or advice or attempt to convince them to feel or think differently. We want to be non-judgmentally acknowledging their distress as understandable in the circumstance and bring it back to their core values. You might hear a lot of times they will say, I did this for my country, I will do it again. And so remembering those things of how it relates to their core values of commitment, dedication, desire for justice. For those with severe trauma exposure, we want to provide education about common stress reactions and signs of PTSD. This would fall under the category of psychoeducation, right? So intrusive symptoms, avoidance symptoms, physiological arousal, loss of sleep. I know all of you are mental health providers, so you're pretty familiar with this. And we want to be also thoughtful and mindful about the psychoeducation timing as well. Obviously, when someone is in high distress, we're not going to be doing that at that moment. This, I think, will come depending on context of how long the frequency that you're going to be meeting with soldiers or any other impacted individuals, but we want to help them with regulating sleep, eating, medication. We want to reduce impulsivity that might be related to drug, alcohol use, and we want to help them maintain some type of a regular, familiar routine. We want to creatively build on their strengths and their interests and their talents to kind of think about adding on to coping tactics. As we all know, most often people have already developed adaptive coping mechanisms, right? But in times of distress, that is compromised. So we want to remember those again and cultivate further ones. We don't want to teach generic prepackaged coping that are not tailored to their personality, culture, or preferences. We want to be thoughtful about not recommending the coping that works for us, but really kind of identifying what will work for them. Here, linking with collaborative services, I think we'd love to hear your experience when you're there, because for us, it's been a little bit of different types of information about what's available where. So if there is a need or a desire for pastoral care, I think we want to help facilitate that. With regard to higher level mental health services, I think we're also referring to psychiatry, depending on how necessary that is, and social services that will help encompass child and family support services as well. So with as Yeraz was mentioning earlier, every time you are engaging with the PFA framework, which really it is a framework and an approach, we want you to think about it as one whole encounter, and we want the session, it can be closed by summarizing or highlighting what they've learned about themselves that give them meaning again. Hoping that they understand that the stress is a normal reaction to their current experience. Really emphasize how they are or planning to be or planning to use their personal strengths to make a contribution that's consistent with their core values. And we want to establish a practical way for them to make contact again. So if you're going to be able to see this person again, it's very important to be able to say, so I'm leaving right now. I'll see you again on Thursday at 8 o'clock, or I won't see you again. However, my colleague so-and-so will see you tomorrow or the next day. Something for there to be predictability. We want to create hope by helping them to focus on small steps or wins that have large meaning based on their core values. This is similar to what we talked about a little bit previously. In terms of specific populations, so all of you, I'm sure, will work with different age groups, but with regard to young children in terms of PFA, we want to match their verbal level with their physical level. We want to have simple labels for emotions. We don't want to talk in complex terms about emotions, right? With regard to teens, though, we do want to speak to them like we would an adult to be able to gain their trust by making them feel respected. We want to check in with ourselves prior to any of these encounters with our special populations. And we want you to be aware of regression. So it's very likely that a child who had gained independence and engaging in tasks developmentally appropriate now has regressed or now needs additional support. It's not necessarily thinking about pathology, but it is thinking about being mindful to normalize this for the parent that might be in significant distress about this. Individuals with disabilities, we really want to address the person, the individual, and not the caregiver that might be accompanying them or in the room. We want to speak simply and slowly if their communication or the communication is impaired. We want to be mindful that not all disabilities are seen, right? There are disabilities that are invisible. We really want to ask simply, what can I do in this moment to help you? And we want to trust that response or affirm that response. And we want to be their eyes and their words to help them get access to services or resources that they may otherwise have a harder time getting to. Helping a survivor who lost a friend in combat. We can go in many, many different directions about this, but really thinking that there will be sort of normalized acute grief reactions, sadness, guilt, regret, a desire and wishing to go back in time to change what has happened. These can be healthy responses. The intervention here is to really normalize, like we were just saying. I think that's a theme that goes across. To really kind of highlight that there is no right way to grieve. We want to say the person's name who died that the soldier might be referring to, not simply your deceased friend or the friend that you lost or your friend who has passed. We really want to refrain from the sort of non-authentic responses. I know how you feel. He went quickly. You're very strong. You're going to deal with this. He did this defending his country, etc. I think we really want to wait to help the individual make those reframes. Okay. Is this me, Yeraz? Real quick.
I think so.
Okay,
Yeah.
so in terms of PFA, actually, there are four seamless steps, but the fourth one is a lot around access to kind of online resources, which Yeraz and I felt like we needed to omit for our current context and population. In the future, we may be able to talk about that again, but at this time, no. So think about VCR, validating, clarifying, and reframing. We want to validate the individual's perspective. We want to show respect for their dilemmas and not start negotiating. We really want to clarify, most importantly, short-term and long-term goals to be able to meet them, hopefully practically. And we want to reframe strength and what they already are accomplishing, which a lot of times, as many of you, all of you know, that during times of distress or high crisis, we have very little clarity in recognizing those strengths in ourselves.
I'm going to add before we go to the next slide that when we were doing these trainings for clinicians in Armenia, there was a lot of discussion around the word validate.
Mhm.
There was some concern of if we sort of enter their experience, are we going to get stuck there? Or are we going to, somebody mentioned some sort of, transference or countertransfer, something like that. Um, so it's just kind of a different framework a little bit. So I just want to alert you guys to that. And we struggled a little bit to express what validation is and what it isn't. So there was a little bit of a just a cultural phenomenon there. So I just wanted to point that out. We could talk about that when we have some of our discussion towards the end of the presentation. So in terms of dealing with, oh, did I go backwards?
Uh,
No, I didn't.
you're right.
No, here I am. Okay. This is me, I think.
Yeah.
So in terms of extreme emotions, how do we react? And again, as mental health professionals, this may come naturally to you guys, but these are really extreme reactions that they're seeing on the ground. So people who are not only confused, but completely disoriented, people who are so agitated and angry that they're really difficult to calm down. I will say, anger is a really normal reaction to trauma, right? And so how do we deal with that? We might recognize and say, I wonder what you're angry about, or it sounds like, you're being really hard on yourself right now. I can see that that's happening for you. Is your anger getting in your way at all? Or is it helping you? I, I'm just curious, because if it is helping you, then let's figure out, I wonder if there's another way that we could help you feel better. And if anger is what you want to do right now, that's okay too. But just know that there might be another way that we could try to make you feel better, instead of punching the wall, because then your hands hurts, and then you have to deal with that on top of it. Um, and I don't know that anger will help you achieve what you want. So it's again that idea of like, is there another way to express this? Maybe we can punch a pillow instead of punching the wall, right? Finding replacements for the anger. For those who are withdrawn or shut down, um, sometimes we just, and even for the agitated person, sometimes just our presence without saying anything can offer so much. So we kind of walk by, introduce ourselves, or just, if they're like, who are you? Why are you here? I'm a psychologist, I'd love to talk to you, but if this is not the right time for you, I'm going to be over here filling out paperwork. We can be standing a little bit to the side, filling out our paperwork, and just be there. And not stare at them, but just be there. And after they've been able to, they may find a way to become less agitated, in which case then we walk over and say, do you want to talk now? Um, for those who are the inconsolable crying, really grounding techniques are going to be incredibly helpful in those cases. So helping them focus on the present moment. What can we do right now? I want to ensure your safety. We're not challenging the emotion. We're not delving deep into that. So some examples might be, someone who says, I have so many people that I feel like I have to take care of. I can't stop. This might be like a family member of a military personnel. I can't stop thinking about my son. I can't sleep. I can't eat. I just can't live this way. So this is if you're dealing with military families. The R of the VCR, so we're validating how they feel. We all know how to do that. We want to clarify their point of view and reflect. And the reframe is how dedicated they are, how much integrity they have, how aware they are that they're struggling to deal with all these different pieces right now, and how they can overcome this, right? How much of a role model they are, sort of the pillar of the family. That's the goal here. The goal is not to delve deep into who they are and why this happened and why they're doing this. That is not the goal, and it can actually harm them in this moment in crisis more than do them any good. For someone else, right? Every moment is another death waiting to happen. This war is unacceptable. Our people need to stop dying. And on top of it, we all have COVID, right? That's the angry person. How can we reframe that? I can see how protective you are about everyone. Well, you've got the worry of everyone on your mind. All of our people are dying. Everyone has COVID and the war. I can see how aware you are of everything that's going on. I can see that you're proactive and you want to do something about it and that you're dedicated to your country and your family and how courageous you are in your ability to protect others. We're reframing, okay? And for those who have suicidal thought, and there have been many, we heard a case of a father who committed suicide after his son died on the front lines. So it is happening, and some of the soldiers are endorsing suicidal ideation, and some of the professionals on the ground are not familiar with or comfortable with this. So what we've been doing in our trainings is talking about this idea that if your life doesn't feel like it's worth living right now, what would a life worth living look like? Let's imagine what a life worth living looks like. What would add to your life in this moment to make it worth living? Let's make a list of practical, concrete changes that can make it feel like their life is worth living. We, of course, want to assess for protective factors, right? So in any suicide risk assessment, we want to, if they're in the hospital and they're not really going anywhere, I don't know how much, we're worried about risk, but in any risk assessment, we want to do protective factor assessment as well. Who are their loved ones? I think most people don't have household pets in Armenia. Some do though, so you could inquire about that. Children, future hopes and dreams. Maybe they have a girlfriend they were hoping to propose to, faith, religious identity, and so on. We can also, although we don't want to do disingenuous reassurance, but there will be a life after war. That we can promise. We know that the war will end. We don't know how it's going to end. We don't know when it's going to end. We don't know what life will look like after. But that all or nothing thinking of it's never going to end, we're stuck in this forever, that can engender hopelessness. And so if we actually open that up and discuss life after war, it reduces the all or nothing thinking and reduces hopelessness, which thereafter will reduce suicidal thoughts. And in terms of the protective factors, we want to also reduce loneliness. That isolation can also be a really key factor of suicidal thought. So really trying to engage and connect them to their loved ones.
Right.
Go ahead.
Oh no, I think I went a little prematurely yet. As I was just going to say, I think in the next slide, you gave the example of a father who took his own life after the loss of his son. Actually, someone in the group that we've been doing the training said or asked, well, how do you console a grieving mother who says, well, nothing in life is worth living again. The permanent loss of my son, there's nothing again that can be worth living again. And the angle there that's a little bit different, but again, under the context of PFA of Reframe in the moment is, so your son, yes, you lost your son. We're not negotiating that. We're validating that loss. That's so deep. And how else are you thinking about the loss of your son? And eventually the mother reframed to say, my son is a hero and I'm going to live my life to be able to tell his story. Now that doesn't happen instantaneously or in that, crisis moment, but eventually if you do get to a place where you can do this type of work with anyone there, I think that's the reframe. That's also part of PFA of, okay, not only in this moment and how else can you think about it?
Yeah, and we don't want to suggest that their son is a hero because they may not be ready
Right.
for that, right? Of
Right.
course, as we said already, we don't want to use the generic terminology, but help them arrive there maybe on their own.
Exactly.
Right. So this we already said, right? My son died yesterday. I have no reason to live anymore. We can do the reframe, ask them about their life worth living goals, and talk about like their own perseverance, their own altruism, how connected they must have been to their son. Tell me about him. What's his name, etc. Look at your perseverance, your dedication, your determination, and your altruism, and so on. So 7, I know we said like there are 8 things you have to do. These are your takeaways. At the end of every encounter, you want to recognize a high impact moment of stress or challenge that they faced, a moment, just one moment of emotional intensity. We want to express and create some exposure to emotion without talking about the trauma. So it's a little bit nuanced for those of us who are in mental health. We wouldn't get this in depth with a non-mental health audience. One moment that was inspiring or poignant for them, one thing that someone else did that made a difference. You know, I was hopeless, and it was literally my best friend made me laugh, and then he was shot and killed, right? Cherishing that moment that made a difference in his life, that moment somehow was created, right? That moment of laughter. One thing that he or she did to make a difference, and remember to keep holding on to those core values and reinforcing them for them, who they are at their core, what they believe in, and one thing that they choose to do moving forward. And so you guys are probably know this, but there can be, of course, vicarious trauma and a lot of burnout and trauma work. So remember to focus on yourselves. I hope you guys set up group consultations there. If you don't, we can help you with that. If you've already got them set up, fantastic. Making sure, and it can help a lot with these consultation groups to have an outside person. Of course, peer to peer, you're going to be doing so much already and supporting one another, but to be able to have someone who's not burnt out with you, providing that for you while you're there, and using your reflective skills. Don't work in isolation. Make sure that you're connected to others while you're there. The big take home is, again, reaffirming core values, making meaning of their distress and confusion, teaching them what it's all about, and being as authentic as we possibly can, to make the world a better place for them in the time of crisis. And with that, I'll stop sharing.
I know you guys are, wanting to maintain anonymity, but any questions or thoughts or reflections?
Hi, I have a couple of questions, if I may.
Sure.
I understand that this is a framework and attendance to immediately reduce certain symptoms. However, the way I'm looking, according to those 5 elements, there's going to be some challenges in the current conditions of in there, and specifically with children, because there's some of the elements that are not going to work, like, for example, connecting resources, like for 150 families in a hotel, and we can't do that. So my question is, what would be your suggestion in that case? That's my first question. And along with that, something connected also with children. I know that one of the issues, actually one of the immediate things that works with PFA is the time relevance. What do we do in that case with individuals that have already passed that time? And let's say I'm specifically speaking people who are at shutdown mode, because I mean, we can use catharsis, right? Emotional expression. But I have another question about. So those 2 questions for now. What would be your advice for us to do, and how would that be relevant to integrate any other modality, including that? Is that going to work, or is that going to contradict in those stories, specifically with children? If you can kind of comment on that.
I have some general comments, right? I think those are great kind of thoughts of reference. And I think when you're on the ground, things will look a little differently than what we've been doing now, which is we have contact with the direct providers there, but we're definitely not on the ground. With that said, I think, the second question, which was around, well, what about the timing? I think for most people, I think we're still in an acute state, right? Yes, a month has passed. So perhaps maybe those individuals who received news of the loss of their loved one from September 28th maybe are no longer kind of in that acute state. But I think from what we've heard, right, from what the providers have told us in Armenia, and I'm referring to about 80 providers, their feedback for us has been that most of them are new incoming soldiers with wounds and injuries that they're seeing maybe once or twice, and then the soldier is either going back to the front line or to another rehabilitation effort, right? So for those folks, I think that's why PFA can remain relevant and helpful, because the acuity remains. It's not as though it's different. Yeah, I don't know if you want to comment on that before we talk about children or.
Yeah, no, I mean, I would agree with what you said. I think it's just important to remember that the majority of the work will be with military and with soldiers, and the severity will be there. So I think most people are really just addressing that. I think the family medicine, the school psychologists, the pediatricians, they're dealing with military families, and they're dealing with coping strategies, and there are, full curricula and many shelters and many facilities for the displaced individuals. And I think that's a separate initiative. We don't know exactly what you guys are going to do, but you did ask us for PFA, so that's
I can
why.
actually describe it to you. Yes, we do have some of the team leaders are going to be in a hospital working with psychiatrists, but some of our participants, actually, I would say probably 50% of they're going to be in a crisis centers, and majority their families, displaced families, and they are even a great number of kids that are unattended as well, that being supervised with. So my question is, would this be in a way relevant in those areas of
Yes.
interest work for our thing? And how do we attend to that time relevance issue? Because I mean, I know that that's also one of the challenges, right, with PFA in general in research, that the time relevance plays a big role and a factor. So it's kindred towards those 5 elements, it kindred towards attending to that. And I understand this is wonderful information and more specific. And I wanted to ask you also later that if we can have some printouts that our participants can have it with them as, like, to refer to.
Yes, yeah,
But
we have those.
this
We can share those
crisis
with you.
center, all right, so this crisis center, this is the difficulty of children arriving in a places more stable in a very later time. So my question is about, if we do attempt to utilize it or try, and what challenges you predict we can face, and how would you, in your opinion, and I know this is just assumptions and approximations, how should we approach that if there are challenges with the time relevance and we are it's not working, for example, the 10 PFA with children like under age of 7, for example. I know that there's a big
So,
number
I
of
mean,
crisis centers that
I think principles like keeping calm and offering a sense of safety and stabilizing and reducing uncertainty can do no harm. So these are basic principles at any age. We do this in terms of reducing anxiety and reducing uncertainty for 4-year-olds and 3-year-olds. So regardless of whether they are coming off the battlefield or whether they are displaced individuals, these strategies are meant to reduce anxiety and to reduce uncertainty and to provide safety and calm. So, are there other modalities? Of course, there's TST, which I think you guys are getting training in or have gotten training in for the displaced population. A lot of distraction and coping and grounding and mindfulness techniques can be very helpful for those who are not amidst crisis. Yes, the literature, I wouldn't say it's sparse on PFA. It's certainly powerful, but is it as powerful as evidence for cognitive behavioral therapy? No, of course, right? It's an evidence-informed modality, and that is the best we have in the trauma work. So if you guys are interested in getting a more specific training for children, we can definitely put you in touch with people for that. We also have access to military psychologists who might be able to do a follow-up training if you guys are interested. And also the TBI training, the traumatic brain injury training that we were talking about. You're going to encounter a lot of things, right? It's not just going to be PFA, and of course, right? And so there's going to be grief and loss work and a lot of other things, of course.
And I think a quick thing to add to
Valentina.
is I think the question of, how do we sort of overcome or mitigate the possible implications or challenges of this? I think that's a really important train of thought. And I think what I'm kind of missing in my sort of conceptualization is that I'm not quite sure yet what that's going to look like, right? So is it a child demonstrating or expressing something that's outside of the normal context of expression, and we're trying to ground them and that's not working? Or what will, I think I would be very curious when you're there too, to give us feedback of, how do we reshape PFA as an initial approach, because this is just about initial approaches, right? But I think some of
Yes,
the
absolutely. Yeah, and sorry to interrupt, but conceptually, my question was arised from because it is ongoing stress of source of stress. So that is going to be the difficulty for us to be able to ground that child. We can't offer the safety when there are adults running around in a hotel and expressing still a concern. So I was just wondering if you have any tips in regards to that.
Well, I know that the Ministry of the Diaspora is working with these cultural centers on the ground. They've got about 10 centers so far, and they're working on more. And they're basically putting the displaced children in like a school. They're doing STEAM work, they're doing art and music, and they're just keeping them busy and connected and socially connected and reducing loneliness and creating calm and creating safety for them and creating structure for them. So, things like that might be good to alleviate the the kids who are kind of subclinical, who are distressed, but are not really, over the line.
Right. And like it makes you wonder, how do you remove them from that context? And I don't know that that's always going to be possible. So then it ends up doing, I'll meet you where you are, right? With how much we can do there.
Yeah.
Yeah.
All
right.
Other questions or comments or feedback? I can stop the recording.
Yeah.